I think good evening to everybody. Pleasure again to be part of this LGS series. I'm going to talk today about tracheal surgery, and as I was just discussing with Dr. Pata, it falls under no man's land. For example, the head and neck surgeons may not want to touch it much. The thoracic surgeons also may be a little iffy about touching it. So I think this is a sort of a area which is coming in a sort of a no man's land. So, but somehow I think being in this oncology field for quite some time, I think we've had a reasonable experience with this surgery. And so I thought I would share with you some tips and tricks which is really important in the performance of this surgery. So again, as in the previous talks, this would only be a broad overview rather than sort of, and of course we will have enough time to discuss. Somehow I think being in this oncology. Yeah, the history of tracheal surgery, I think Dr. Patel loves history and a lot of his updates are on history, I think. So I thought like it's very important for us to understand the history. In the times of COVID that we are now, I think I take you back to one more epidemic, not pandemic, of course. This was the 1950s. It was a polio epidemic. And at that time also parallelly what we witnessed an evolution in ventilators and also in the use of cuffed endotracheal tubes. No doubt, the introduction of ventilators and the cuffed endotracheal tubes saved a lot of life, but because of the rigid nature of these tubes, what it caused is it caused a lot of pressure necrosis and injuries in the trachea and caused a lot of tracheal stenosis. So surgeons were called in to correct them, and it gave birth to the field of tracheal surgery. During the 1960s, the surgeons believed at that time that there were not more than 2 centimeters or 2 or 3 rings of trachea could be removed at a particular given time. The reason was because of the inflammation, the cicatrization post the injury caused by the endotracheal tubes. So it was called as a 2 centimeter rule, which is very common and very popular in the 1960s. But now we know that the 2 centimeters rule has expanded. Now we are in an era of a 6 centimeter rule. Now we know that almost half of the trachea can be resected and an end-to-end anastomosis can be done. One must remember the 3 musketeers, as they are called, of airway surgery. In the center is Professor Hermes Grillo. He's also called as the father of modern tracheal surgery. And flanked on either sides is Professor Pearson and Professor Queenard. And these 3 gentlemen have actually revolutionized the way in which we actually practice. Some of their surgical atlases are so elegant that the principles of tracheal surgery enunciated by these 3 gentlemen we follow even to this date. Now, even in 2020, if you see, nothing much has changed. The most common cause of tracheal surgeries is iatrogenic airway injuries, and this is caused because, especially in ICU settings where there is a post-intubation trauma or post-tracheostomy trauma. So we need to be really vigilant as clinicians and intensivists to prevent the occurrence of such injuries. But as surgeons who are more interested in the field of oncology, we would go into a little bit of some primary neoplasms of the trachea, which is in fact rare. The squamous cell carcinomas and the salivary gland tumors form a major part of the primary neoplasms. Secondary neoplasms, in fact, this is the area in which we have got a lot of experience. Thyroid neoplasms with involvement of the trachea, hypopharynx or pharyngeal neoplasms with involvement of the trachea. Apart from that, you've got a lot of other diseases like autoimmune diseases, especially vaginous granulomatosis, which can affect the trachea. And of course, as in any other condition, you have got the congenital and the idiopathic roles. Before going into the tracheal surgery, it's very important to understand the applied anatomy of the trachea. It's 11 centimeter long tube from the lower border of the cricoid cartilage up to the level of the carina, right from the C6 to the D4. Each of the centimeter has about 2 rings. So in all, you would have up to 20 to 23 rings. One must also remember at this point, we don't really have a robust replacement for the trachea. Of course, this is something that we will allude to later. More importantly, we must understand the blood supply of the trachea. The upper trachea is principally supplied by the inferior thyroid arteries and the lower trachea by the bronchioles and many other vessels. But more important than that is the segmental blood supply of the trachea, which is shown in this figure. And note that most of the blood supply of the trachea comes from laterally. A large bit of the anterior portion of the trachea is actually devoid of any actual vasculature. The vasculature actually comes laterally forms a longitudinal anastomosis and a submucosal plexus. So this is very important. For example, if you have a circumferential stenosis or a lesion in the trachea, you must not go more than 1 centimeters on either sides of it. Otherwise, you would have a serious jeopardization of the vascularity of the trachea. Also, it is very important to understand that the trachea moves with the neck movements. In a normal adult, about a half of the trachea will be present, about a third of the trachea rather will be present in the neck. If one is hyperextending the neck, more than half of the trachea will be present in the neck. On contrary, on flexion, what you find is almost the entire trachea may actually go into the mediastinum. So these movements are very important for us to understand because we use a lot of these movements during the aiding of the tension-free anastomosis. One must also be very careful at this point of time. If any patient, especially an elderly gentleman or elderly lady with a cervical spondylosis, you may not be able to extend and flex the trachea as much as you would want to do. And sometimes you have serious cervical injuries leading to quadriplegia and quadriparesis also in these patients. So one must evaluate not just the trachea, but also one must evaluate the cervical spine in these patients. I said there are benign tumors, the hamartomas, the papillomas, and these are very rare. The malignant tumors are also quite rare, squamous cell carcinomas and adenoid cystic carcinomas. More commonly, that what we see are thyroid cancers and laryngeal cancers, which actually go about and involve the trachea. Now, coming to the basic evaluation of the trachea, and it is to come to the symptomatology. Primary tracheal tumors, majority of them could be asymptomatic or could present with non-specific symptoms of asthma or COPD like cough, wheeze, or shortness of breath. And that's the reason why in a substantial number of patients, there is a delay in diagnosis, sometimes up to the tune of 1 to 2 years as well. The stridor which comes is actually coming in only the advanced cases and not the early cases. And one must be astute to differentiate the cough and wheeze that is caused by a tracheal tumor from a supraglottic or a laryngeal tumor in which you would get a stridor. The reason why you must differentiate it is that you do not want to rush and go do a tracheostomy for a patient who has got an inspiratory stridor because of a tracheal tumor. Otherwise, you would have a big problem because you may have an intraoperative catastrophe because you may actually enter through the tumor and cause some bleeding problems. And even if you are lucky enough to get away from this, you may actually jeopardize the patient's chances of having a definitive surgery at a later date. So physical examination, again, it's all very important. You must have a high degree of suspicion. And for secondary involvement, for example, like thyroid tumors involving the trachea, you may have telltale signs of non-intrinsic mobility, fixity to the surrounding structures. And these are certain things that you can definitely elicit on a physical examination. And what you need is, in such cases, you would need to go ahead with a cross-sectional imaging. A cross-sectional imaging gives a reasonably good roadmap for all the patients, and you would exactly know the length and also whether it is coming from the intrinsic component or the extrinsic component. You would get to know in a good cross-sectional imaging. But what is more important is that you could ask for a software called as a virtual bronchoscopy. It's nothing but a CT reconstruction of the trachea, as it is shown in this figure. You can see what the distance of the lesion is from the cricoid or the subglottic area and the distance of the lesion from the carina, and you will get a good roadmap. So a good virtual bronchoscopy, which is just nothing but a CT reconstruction, will give a good roadmap of the disease. It's important that when you are dealing with a thyroid tumor which is infiltrating into the trachea, I would recommend everybody read this paper, classical paper by Shin, which came out in 1993, and this is something that we follow even today. Stage 1 and 2, which is just about a little bit of extrinsic evaluation, compression on the trachea, and stage 3 and 4, we have wherein you have gross mucosal or perichondral involvement. It is important because in stage 3 and 4, you have to do a circumferential resection of the trachea, whereas in Shin stages 1 and 2, you may get out ahead or get away with a lesser sort of a resection. And the actual bronchoscopy, what we saw till now was a virtual bronchoscopy, which is a CT reconstruction. The actual bronchoscopy is also very important to know whether there is intraluminal involvement. Quite often you tend to take biopsies to get a tissue confirmation from the actual bronchoscopy. At times, you may have an extraluminal involvement of the serosa of the esophagus as well. So sometimes you may have to do an endoscopy for these patients. As I said, biopsy confirmation, more often than not, we tend to get it from the intraluminal component. If there is a large extraluminal component, you could get it by a percutaneous FNAC evaluation. And this is very important, a voice assessment. For any thyroid surgery is also very important, even more important for a tracheal surgery. You must involve a formal speech language pathologist in doing this assessment. You must again know the status of the vocal cord. At this point of time, I would like to tell that involvement or paralysis of one recurrent laryngeal nerve is actually not a contraindication for a tracheal resection. We have got some cases in which we have done this. So if you have to have a normal functioning trachea or an airway, one functional cricoarytenoid unit is enough. So per se, involvement of one recurrent laryngeal nerve is not a contraindication for surgery. It's very important to take informed consents for these patients, and most of the times we tell the patients that it could have complications, even life-threatening complications, or sometimes you'll have complications that would land up in a laryngectomy. What is most important is it requires a real multidisciplinary team. You have to have a good anesthetist in the team, and it's very equally important. Whenever we are scheduling a tracheal surgery, it's very important for the surgeon to be inside the operation theater right from the time of patient induction, because anything could go wrong at any point of time. Generally, the anesthetist or anybody who is trained in fiber optic nasotracheal intubation will do that under some sedation. If the tumor of the lumen is narrowed because of concentric stenosis, because of the growth or anything else, you could use a flexible pediatric bronchoscope under topical anesthesia. Have the facility for a jet ventilation at times, because this may help, because sometimes achieving the airway may be a little tenuous. But what is very important from the operating room setup is to have a rigid bronchoscope. And I reiterate that the presence of a rigid bronchoscope can be life-saving in a lot of these patients. Along with the rigid bronchoscope, keep little dilators. If you have the facility for a laser, have them there. Keep endotracheal tubes, especially the flexometallic tubes of various sizes. Keep a sternotomy set also ready, because at times you may have to do a sternotomy, and I would sort of come back to that in some time. If you have the luxury of having an ECMO, nothing like that. Of course, we don't really have a work in a setup that an ECMO and a bypass is there. But if you have an ECMO and bypass, you could actually do the surgery practically very, very easily. Now, again, coming to the principles of tracheal surgery, I think these are pretty much very standard, and each of them is extremely, extremely important. One is actually, more importantly, is the resection of the diseased segment. And as I said, I reiterate, you should not go more than a centimeter on either sides of the diseased area. It's very important to preserve both the recurrent laryngeal nerve, or if you are functioning, if you're operating in a case in which there is only one functional nerve, it is exceedingly important to preserve that nerve. Otherwise, your surgery will be very futile. More importantly, it is important to preserve the blood supply which comes laterally from the trachea. You must have adequate mobilization of the trachea, and it all is very important. We'll come to that in the later slides. And again, as in any anastomosis, be it a skin anastomosis or a gut anastomosis, you must do your anastomosis without tension. And I will tell you the choice of suture materials that we use. During the entire performance of the surgery, the anesthetist should ensure that adequate oxygenization of the patients is done, because at times you may have to do several tube exchanges, and at that time you must closely liaise with your anesthetist every time that you're doing a tube exchange for these patients. Now, it's very important to know when not to do the surgery, and this is important not just for tracheal surgeries but also for very other surgeries. More than half of the trachea involvement is a relative contraindication. I must say that none of these are actually absolute contraindications. Most of them would be relative contraindications. Up to 6 centimeters of the trachea, or 10 rings you could remove and still get away with the primary end-to-end anastomosis. Prior radiation is a relative contraindication. Problematic anatomy, this is especially in cases of redo anatomy, and in medical contraindications, supposing the patient has a lot of medical comorbidities, especially COPDs, that they may not be fit for a tracheal resection surgery. And this is one of the surgeries. In fact, this was the surgery that we had done just for 10 days back for an early Shin 1 thyroid cancer. As you can see, there is an involvement of one of or half of the of a tracheal ring that has been taken along with the thyroid carcinoma, which is involving just the outer lamina of the thyroid cartilage, in which case you don't really require anything. You just need to buttress that area with the adjacent sternocleidomastoid muscle and get a good closure in these cases. There is something called as a window excision, and I would urge you all to look at this picture because I would come to this picture at a much later date. This is in which a part of the tumor is extending intraluminally, and you excise only that part of the trachea and leave it to heal with secondary induction or heal subsequently as a redo surgery. The preferred approach in majority of the cases is a circumferential resection. That is, you resect, you bread loaf it on either sides, and then do a primary end-to-end anastomosis. And it's very important to go in the planes of dissection based on the blood supply. And this is very important, the release maneuvers, and these are the most tricky maneuvers that you do when getting an anastomosis. There are three maneuvers that we do. One is called the Montgomery's maneuver, one is called the Dedo's maneuver, and the other is called as the thyroid release. So in the Montgomery's maneuver, what you do is, I think people, ENT surgeons or anybody who are familiar with the performance of the laryngectomy, these maneuvers are pretty much elementary. Even otherwise, anybody who is doing a neck resection, as shown in the cursor, this is the hyoid bone. A suprahyoid release is called as the Montgomery maneuver. A thyrohyoid release is called as the Dedo's maneuver, and each of these maneuvers would give anywhere between 1.5 to 2 centimeters of length of the trachea. The other mobilization that you could possibly do is the mobilization of the mediastinal trachea and the anterior part. And invariably, if you do all these maneuvers or one or two or three of these maneuvers, you would easily get, sometimes you could also do the release of the cricothyroid membrane. You could release a little bit of the cricothyroid membrane. So in effect, what happens is the whole unit really sorts of moves together, and you would be able to anastomose it as in a primary end-to-end fashion. Sometimes you may have to do what is called a sternotomy, and it is very important because not all the necks are the same, and we must appreciate that some necks are very short and stubby, in which case you may not be able to do one or more of these maneuvers without doing a sternotomy. If there is some difficulty in doing a sternotomy, what we can do is we can also get much more leverage by doing what is called as the inferior pulmonary ligament release. You can do a hilar mobilization. That is, a hilum of the lung can be mobilized by incising of the pericardium. Sometimes the left bronchus intermedius can be amputated, the left main bronchus can be amputated, and it can be anastomosed to the right side bronchus intermedius. So all these maneuvers are very rarely required, but have been very elegantly described in the Grillo's textbook and the Grillo's sort of paper. And I urge everybody to read this paper if at all they want to do any bit of the tracheal surgeries. Again, it is very important that you must release only the amount that is actually required. For example, if there is a tumor that requires only a 2 centimeter release, you must not go and release the entire 6 centimeters. Otherwise, you would jeopardize the functionality of this patient. So the need of the release will be determined on the need of or the extent of which the resection that has been done. And you, as I reiterate again, that you could sort of, resect up to 6 centimeters or up to 10 to 12 rings, but majority of the times we would not go in that way. The maximum that we have resected in our series is up to about 7 centimeters. Again, tips for anastomosis. I think this is same for majority of the anastomosis. The anastomosis of the trachea is no different from either a gut anastomosis or any anastomosis anywhere. I tend to use a 2-0 or a 3-0 vicryl, but you could use any of the suture materials. Preferably, you must use only absorbable suture materials. It could be either PDS, Maxon, or anything of your choice, but my preference is to use the 2-0 and 3-0 vicryl. Initially, I used to use the interrupted technique, but now I think more and more with the performance of more and more of carinal resections and sleeve resections of trachea, we are shifting to more usage of the continuous techniques. If we do a partial cricoid resection or a laryngeal tracheal resections, then they add complexity to these, and these are very, very tricky procedures. So again, At the end of the surgery, I think this is where we are that, after doing the releases, we are doing an anastomosis. When you are doing the posterior anastomosis, we take the endotracheal tube off. The patient gets ventilated through the endotracheal tube that is placed intraoperatively here. And once you're completed with the posterior anastomosis, you take the intraoperative sterile Ryle's tube, ask the anesthetist to push the endotracheal tube inside, and then subsequently do an anterior anastomosis. At the end of the procedure, we do what is called as the intraoperative leak test. So what is done is we flood the field with normal saline. We ask the anesthetist to withdraw the endotracheal tube to some extent and give positive pressure. So in case there is any bubbling, it will be noted intraoperatively, and that would actually, you could reinforce that particular area. But if you have done a proper mobilization and a proper anastomosis and the intraoperative test is negative, it is highly unlikely that you would have a major problem at any point of time. Again, at the end of the surgery, what we do is we take what is called as a guardian stitch. The guardian stitch is nothing but a stitch taken from the mentum to the sternoclavicular joint of Louis. And this is a loose thread, a loose stitch taken with Proline 102 Proline or any other absorbable material. And the reason we take these stitches to prevent the patient from hyperextending. Hyperextending may cause some tension of the anastomosis and can occasionally lead to disruption of the anastomosis. Again, I told you about the movements of the neck and the trachea, and this is very important. After the performance of the surgery, we tell the patient that they should not hyperextend, and that is the reason why we put what is called as a guardian stitch to ensure that the patient is in a neck flexion. What we tend to do, and what is something different from many other series, is we tend to extubate the patient on table and keep the fiber optic endoscope, bronchoscope ready by the site. And this is some contentious issue. Earlier in our series, we used to keep the endotracheal tube for 24 hours and shift the patient to the OR the next day and extubate. But then a lot of series have found that this could increase the infectious complications, and that's why what we have shifted right now is to do an immediate extubation on table if we are very sure of the integrity of the anastomosis. Of course, we keep a fiber optic bronchoscope by the bedside of the patient every time, along with endotracheal tubes available in case there is any airway emergency. The resident who is there is instructed to do a careful bronchoscopy and railroad the endotracheal tube beyond the anastomosis. Of course, this is our data, and as I said, that we have got a lot of data on thyroid cancers with tracheal resections. We've had more than 50 tracheal surgeries, but as I said, a majority of them are for thyroid cancers which are infiltrating the trachea. What we did in our series, what we found rather in our series of trachea, is that we had a good follow-up. This was a 15-year follow-up of our cases. We have quite a good follow-up of our patients. 175 months was our median follow-up in our cohort. And what we see is a 15-year survival of around 35%. So the 5-year is 80%, 10-year is around 47%. And believe me, these are thyroid cancers which are actually having the extra thyroidal extension. So these are certain cancers which have a slightly poorer prognosis. Despite that, having a tracheal resection, some of these cancers, we are able to get 15-year survivals of close to 35%. So that means these surgeries are really worthwhile doing. So this is the comparison of our complications from our series, and I must tell you that it looks pretty simple, but doing the surgery requires a lot of skill and expertise. Of course, once you've done things right, then it's very easy to get the both ends together and do an end-to-end anastomosis. But series have showed we've had about 1/5 of patients have got some sort of complications of morbidity. Although we didn't have any mortality in our series, it has been described in literature. Morbidities up to 40% or so have been described, and we've had morbidities ranging around 18.9% in our series. And I would briefly come to the morbidities in the next slide. Interesting finding which was seen in our series was in our thyroid cancer patients with tracheal resection. We found that even the poor risk histology, or even if surgeries were done in a metastatic setting, or even when they're in a recurrent disease or in a metastatic disease, still patients seem to benefit long term. For example, this is one of the very unique cases that we had. Very quickly, I'll run through this case. A 40-year-old gentleman who in 1998 came to our institute. He had a thyroidectomy with a central compartment neck resection and a window tracheostomy. I think remember the slide I showed you earlier of a window resection. He had a window tracheostomy. Window resections are something that we don't do at this point of time, but this gentleman had it at that particular point of time. He came to us in 2003 with a stomal recurrence. I'll show you the pictures in the next slide. He did not want to undergo any treatment for the same. He just underwent some sort of a palliative radiation therapy at that time. 5 years later, he again presented back to us with a stomal recurrence, and this time he came up with lung metastasis. This was the picture at that particular point of time. This was not a laryngectomy picture, but this is a picture of a window tracheostomy done for this gentleman with a stomal recurrence. And subsequently, we actually went ahead with the surgery, despite the fact that he had a metastatic setting. And he went along to live for about 5 more years following the surgery. And a good 15 years after his index surgery, he actually succumbed to his disease. But he lived with metastatic disease for close to 10 years. That goes to saying that in a well-selected patient, you do get very robust long-term survivals. Of course, we went on to publish this case earlier in 2013. Complications, I touched upon very briefly the complications, but the early complications are, again, like any other surgery, bleeding, infection. The most dreaded complication is anastomotic dehiscence, and this is something that we have to be really careful about. Vocal cord paralysis is something that's very crucial. In fact, I keep one of the residents and keep telling them to actually look at the recurrent laryngeal nerve, because having done a tracheal cut on either side, sometimes when you are moving these structures here and there is a tendency of the recurrent laryngeal nerve getting hitched in one of the suture lines. So you have to be really very, very conscious. Every stitch you take, you must orient yourself where the recurrent laryngeal nerve is, to prevent any inadvertent take of the recurrent laryngeal nerve in your anastomosis. Despite sometimes you do get some sort of paresis or paralysis of these patients. A lot of times you do get a little bit of anastomotic edema also at times. And rarely you may have life-threatening morbidities and mortalities also in such patients. The late complications, of course, are granuloma formation, restenosis, and this is especially true in cases in which you have operated for a patient who had a tracheal stenosis due to a iatrogenic trauma. Other complications like tracheal fistulas and the dreaded Tracheo-Innominate Fistulas have also been reported. We must be very careful in our choice of patients, especially for diabetics or patients as obese, or if it's a redo surgery or a prior radiation, and these things are very tricky, especially if there's one vocal cord paralysis. We must be very, very choosy and very, very conscious of how we choose our patients. So these are the predictors of complications. If your patient has one or many of these things, you must think twice or thrice before taking these patients for tracheal surgeries. One important thing from the clinical perspective is the presence of subcutaneous emphysema. Normally, a little bit of subcutaneous emphysema may be expected immediate post-operative period. But if there is a subcutaneous emphysema with an element of respiratory distress or stridor, then that means you're in trouble. It's an imminent sign of anastomotic dehiscence, and you have to be really very, very careful, very quick. Go intubate the patient very carefully with a fiber optic endotracheal intubation or a rigid scope, whichever is your technique, and then subsequently go about the surgery. This was one of our patients actually who had such a problem in which they had an anastomotic dehiscence, and subsequently it is shrinking down. So we did a tracheostomy through the same incision, and she is due for closure. So some odd cases you do get some emphysema, and we have to be very, very careful, especially if they are associated with respiratory distress. As I said, Tracheo-Innominate Fistulas, these are very rare. This is something which is taken from the literature. I think these are very dreaded complications, and in the presence of a secondary infection, you can have a blowout in some of these cases. So we've thankfully never had this, but this is something that can be expected in any case of larynx or hypopharyngeal surgeries as well. Generous use of stents can be done. This is one of the patients who was not fit for surgery, and we did a tracheal stent, as you can see in the tracheal stent placed in this gentleman. You could use a SEMS in this patient as a self-expanding metallic stent, or sometimes you could also use a plastic stent or a Montgomery steel tubes. I think it'll be very comprehensive, so I don't really want to go into too much details of how you use plastic stents in these patients. But suffice to say that in terms of some complications, a generous use of the plastic stents can help us tide over the crisis. Adjuvant treatment for these patients are important. For example, if the primary tracheal tumors of adenoid-cystic carcinomas or squamous cell carcinomas, a lot of them, by virtue of the extension of these tumors, would require radiation therapy. If it's thyroid carcinomas, then you would require radioiodine therapy apart from enteroxin suppression for these patients. Now, very finally, I would end by saying going beyond end-to-end anastomosis, and these are certain things that have been tried over the years, tissue engineering techniques, tracheal transplants. Of course, these are things that are not been new, that they've been tried earlier as well. You have synthetic options like the Marlex mesh. You have a lot of the allografts like the aortic allografts of free flaps that have been used. There have been episodic successes. For example, you have had patients who have lived to up to 28 years also post a transplant as well. But again, I think the case series are far and few. Some case series have, believe me, mortality rates up to 45%. And a lot of these patients have innominate blowouts and they actually die. So the results are not greatly predictable, but these are something that you'll have to watch out for. And I think if at all we have a tissue engineering in terms of a tracheal transplant, then that would extend our scope of resections for tracheal tumors. So finally, I would conclude by saying that the key elements for a tracheal surgery would be a proper patient selection, a meticulous surgical planning, and for that you must know the applied anatomy of the trachea. Your technique must be very robust in terms of your resectional techniques, in terms of your mobilization techniques. Just mobilize the amount of thing that is actually required for that patient. And it is very important even in the intraoperative and the postoperative phase that you diligently follow your patients for any stridor or respiratory distress. And very importantly, you must talk to the patient. You must tell them what is expected to them. You must tell the patient that if they have any symptoms of respiratory distress, report immediately. Or if you notice as a resident, if you notice some sort of emphysema in these patients, you must immediately report it. And it is always important that whenever we do a tracheal surgery, at the bedside of the patient, we keep a fiber optic bronchoscope, we keep some tubes ready, because God forbid they go into respiratory stridor at any point of time, then you don't keep running helter-skelter for things. You immediately take the fiber optic bronchoscope and immediately intubate the patient on the bed of the patient itself, and then subsequently go about doing the definitive correction for these patients. So I think with that, I would sort of end my talk, and I would we'll take up questions, sir, and based on how to go about. And thank you once again for the opportunity, sir.
Thanks, Arvind. Again, another beautiful talk, crisp talk from you. And then most of it is all eye-opening for me, because in my era, I never seen much of anyone doing tracheal surgery, and this is really wonderful. Any questions from the audience, please? Yeah, Karthik.
Good evening, sir. Karthik, sir.
Yes, Karthik.
So there are a couple of questions, sir. When will you consider endotracheal ablative procedures, sir?
No, generally curative procedures involve resections. So if the patient is not fit for a curative surgery, then you can go for endobronchial procedures. There are some situations, for example, as an emergency to tide over a crisis, you can do some sort of a bridge procedure like endoscopic procedure to sort of take before taking up the patient for a definitive surgery. So there is definite role for an endolaryngeal or endotracheal surgery as a bridge procedure before doing a definitive procedure. Or in patients who are not able to tolerate a definitive procedure, you can use it as one of the.
Sir, and regarding in case of a primary tracheal tumor, how will you consider the margins, sir? Though it will be purely based on the histology, will you go for a mucosal margin or a?
Yeah, it's a very interesting question, a very important question as well. As I said, that you would achieve a negative margin, and if you are able to achieve a negative margin, you should feel it is good. The problem arises if the tumor is only intratracheal, you would not be able to know where the cut is. But invariably what happens is you would say some telltale signs. So it is better to go and take the first cut very close to the tumor, and subsequently you can go about revising the tumors. So it's very important in such cases not to take too much of a margin. If you take too much of a margin, then you'll have to do that extra bit of mobilization and closure. we tend to sort of, try to achieve a centimeter margin macroscopically, but quite often than not, if you see in the series, there may be a lot of series, especially it comes in adenoid cystic carcinomas, which has a tendency of perineural spread. A lot of times what happens is these patients tend to have microscopic margin positivities. So even in literature, up to 20 to 25% of the times, you do tend to get patients with margin positivity. But as I said, the main aim of surgery is to achieve a gross negative margin. So you tend to go up to a centimeter on either side.
And one final question. And in case, as you said, all the maneuvers we are done to ensure adequate mobilization, still we end up with inadequate length. What will be what will be the surgeon's rescue at that point?
No, that is that's a very tricky situation. I think, as I said, so a lot of times we do take consents for laryngectomy or for these patients. So if you are able to not get anything at all, then the last resort would be a laryngectomy. But generally, I think such things should be avoided. What I feel is a good pre-operative planning and selection would actually sort of help you not get into the crisis. But I know that having said, a lot of times you may land up somewhere something. So before making a definitive go or no go decision, you must ensure, like for example, there have been cases in which we have felt that the extra tumor which was there in the extratracheal region was so bad, the tissues were so bad that we actually went and abandoned that surgery. So you must be a little astute whereby before taking the go or no go decision.
Thank you, sir. Thank you.
Yeah, Dr. Nikhil, do you have a question? Arvind, there are a couple of questions in the chat box. If you can open the chat box.
Yeah, I am saying that for distal tracheal lesions near carina, how far we proceed to an EA? For distal carinal tumors is a completely different ballgame. So you will have to do a sternotomy for these patients, and you will have to decide based on how to go about. There are 4 or 5 ways in which we resect the carina. There is sometimes whether you must decide whether you can preserve the lung or not preserve the lung. So carinal resections are very, very tricky, I must say. So, but as I said, you do a sternotomy for these patients, do a good intraoperative mapping for these patients, and then you can sort of decide. There are cases in which they have done carinal pneumonectomies as well. For example, they have done a pneumonectomy on one side, they have taken the remnant of the trachea and they have closed the defect based on that. You can actually amputate both the ends and try to get them together as well. But these surgeries are very, very tricky, and they have to be done with the keeping the cardiothoracic surgeons with you, or sometimes some of these surgeries are very easily done with ECMO as well, because maintaining the oxygenization during the performance of these surgeries sometimes is difficult. You may have to take the endotracheal tube and selectively put it in one of the bronchi to sort of keep ventilating. The other question is opinion surgical management tracheal tumor involving the cervical esophagus. Generally, I think you must know what is the histology for these tumors. Quite often in our series, what we have seen is in thyroid cancers, which is invading the trachea, the involvement of the esophagus is only the serosal involvement. They don't tend to penetrate beyond the serosa. So it all depends on the histology. If it's a papillary carcinoma thyroid, then you're good. You'll be able to sort of get a good resection by removing, if at all, if necessary, some of the serosa of the esophagus and make sure that the submucosal area is kept intact. However, if it is a squamous cell carcinoma, if it's then of course the options are different. Then you may have to sort of see, based on the extent of the disease, you'll have to see whether larynx preservation is possible.
I remember reading an article on a scam by an Italian surgeon making artificial trachea. Can you throw some light on that?
I'm aware of that. And in fact, that is the issue of tracheal transplants, what he claimed to have done in a very reputed university. And he came enormous successes. And I think it's an Italian surgeon, Manzioni, or I think his name is, I'm not able to get his name correctly. But as I said, like in a lot of these series, the mortality rates have been pretty high. So they have been up to about so what happens is they keep some synthetic material like a Marlex mesh or any other tracheal substitute. So till now they have not actually got a good tracheal substitute. So in effect, what happens is sometimes granulation tissues comes in into the tracheal transplanted trachea, and then they tend to throw up, showing a lot of secondary hemorrhages. So apparently in these series, I think the resident, I guess, who was working with the surgeon was not able to sort of see the mortality of patients actually bleeding or throwing blood. And so I think he turned out to be the whistleblower, and then I think a lot of these cases had to be taken off. Having said that, even in other reported series also, you've had rejection rates, if we've had deaths happening or life-threatening mortality happening due to bleeds. So till now, we are not able to get a robust replacement of the trachea. So what we can surely do, that is, as sort of surgeons, what is within our control is to sort of do a good circumferential resection and have an end-to-end anastomosis. If you restrict our case selection to sacrificing just about 6 centimeters or within about 8 to 10 rings and not more than that. In fact, if you want to sacrifice anything more than that, only the problem arises. Majority of the cases that we get, or at least we take up for surgery, fall within that realm. So as I said, it's very important to do a proper case selection and try to know your limitations and try to work around the fact of trying to get a resection with a primary end-to-end anastomosis.
Yeah, there's one more question in the chat box, Arvind.
Yeah. Tracheal resection for carcinoid, when we have to go beyond intratracheal resections. I think this is a very good question. And the question, Dr. Dharma. I think there is an issue about the carcinoid, because some of the terminology, of course, now keeps changing. They're all called as well-differentiated neuroendocrine tumors. So the carcinoid was a slightly older terminology. The fact remains that some of these well-differentiated neuroendocrine tumors tend to do very well in the long run. So we do have a lot of interventional pulmonologists trying to sort of take some of these tumors and manage to do some of these tumors through endoscopic procedures. So, but I must say that if you really want to achieve a definitive cure or long-term cure in these patients, then a surgical resection could be worthwhile. But having said that, I've known very good interventional pulmonologists able to manage some of these tumors, and this is very important because of the fact that a lot of these tumors do very well in the long run. So when you know that the biology of the tumors are pretty indolent, then there are a lot of intervention pulmonologists who want to do lesser and lesser, because having said that, a majority of the carinal resections or the sleeve resections are very, very morbid procedures for these patients. Of course, we can do them with video-assisted thoracoscopic procedures as well, and sometimes even in uniport, and sometimes what they do, some of these surgeries have done under awake anesthesia as well. So there have been certain selected centers which keep doing it. But having said that, I think such surgeries are pretty morbid, and endoscopic resections are maybe a reasonable alternate in patients who do not wish to undergo such surgeries, or in whom they feel that the option is given and they choose to undergo that surgery, or who refuse an open surgery. The other question is the sequence of release. Yeah, I think we tend to do the Montgomery maneuver first. And as I said, it's a very important question. The sequence of the release is that we must release only the amount that is required for the defect. And I reiterate that is very important. Mediastinal release is something that you can easily do. And while the performance of a transhiatal esophagectomy, invariably we go in that plane, or doing a mediastinoscopy, we tend to go in that plane. So mediastinal release is something that doesn't jeopardize much, so that can be tried first. If you are not getting the adequate length, then you do a suprahyoid release or the Montgomery release. And while doing the Montgomery release, it is very important that we don't really go very deep inside and do a pharyngotomy at that particular place. Otherwise, two things can happen. You'll have to close it, of course, with primary closure. Patients can have leaks and infections. So this more important thing is, a lot of these patients tend to have some swallowing difficulties. So that's why it is very important not to overdo the releases to a great extent. And as I said, each of these maneuvers tend to give about 1.5 to 2 centimeters. So 2 into 3 is 6 centimeters, and that's the maximum length in which you could possibly safely do an anastomosis. In some patients with a favorable anatomy, you could possibly stretch the indication. The other question, please tell us more about tracheal stents. What is the distance between the lesion glottis to place the stent? Yes, I think there are two types of stent. One is the self-expanding stent and one is the plastic stents. Plastic stents, we generally use it as a bridge between, if you want to do a definitive procedure later, or if there is a stenosis that has happened in a post-surgical field, then you tend to use some plastic stents. Some of these patients do develop a lot of tracheal edema and also develop a lot of laryngeal edema. So sometimes we use what is called as, these are called T tubes also. It's called Montgomery's T tubes. These are also called as some sort of a plastic stents. They can be placed in the supraglottic region. They can be placed in the tracheal region. So these are as a bridge to sort of, in case of stenosis that happens or edema and stenosis that happens in the post-operative setting. The definitive stents, that is self-expanding metallic stents, can be placed for some of the tumors as a purely a palliative procedure. In case of malignant tracheo-esophageal fistulas, you can actually, in some cases, you can use a double stent. So the plastic stent uses a bridge, the self-expanding stent. Again, I think these stents are easy to place, in which there are 2-3 types. You could use it either by deploying it by a rigid bronchoscope under CM guidance, or you could use it by a flexible bronchoscope using a CM guidance. And it's very easy. You just place it is just like deploying an esophageal stent. The only thing is that we'll have to be really careful, because at a particular point of time the airway will be compromised, so you'll have to keep an anesthetist by standby. Sometimes jet ventilation. A lot of times what happens is, when you are dilating some of these tumors, they tend to bleed. We'll have to be really careful. In one of the cases in which I think there was a bleed which happened to a patient, but fortunately he was not under deep anesthesia, so he coughed out and the clot came out, and then the patient was better. So some of these procedures, especially tracheal stentings, can give you occasional nightmares as well. Okay, a lot of questions. I said in advanced cases it can present with stridor. How to differentiate between a tracheal involvement with that of a... No, I think it will be slightly difficult. As I said, once the case is becoming very, very advanced, it is very difficult. But generally, tracheal tumors, we have to go more by the history of these patients. Most often, tracheal tumors present with symptoms that go on for years together. They have initial symptoms of COPD. They may have a wheeze. They may have a cough. They won't have classical stridor. They may present in stridor only in advanced cases. And that's why there's a lot of delay in diagnosis of primary tracheal tumors. And this is also true for even carcinoids or salivary tumors of the distal trachea as well. But in cases of laryngeal tumors, I think the stridor tends to present more often, and it tends to be very obvious. Having said that, the more reliable way for us to see is to have a chest X-ray, and also if you have the time, then you may have to, if a CT scan is available, there is nothing like that. So a good roadmap is required, and as I said, it's a very astute history and suspicion, but some clinical examination based on telltale signs. If you are able to see some sort of a growth on a indirect laryngoscopy or some flexible scopy, then you know that it is a laryngeal tumor causing a stridor, and then you may go ahead with a tracheostomy. But I agree, in purely advanced cases, it may be a little tricky issue. The maximum resection end-to-end anastomosis, maximum resectable length, do we have any centimeters? So no, I did mention that. 6 centimeters is a reasonable cutoff, and as I said, every centimeter has got up to 2 centimeters, 2 rings, sorry. So you may go up to a maximum of 12 rings, but I think that's too much of a call. But there have been reported series in which they have removed up to 6 centimeters or 12 rings. But having said that, the maximum that what we have gone is about 4 centimeters and 8 rings. So, and as I said, it purely depends on the anatomy of the patient. If the patient has a long neck, tissues are very, very pliable. If it's a young patient, then what happens is some of these cartilage does not undergo any sort of an ossification, so they tend to sort of move more easily. So you may be able to get that amount of length. So the golden rule is around 6 centimeters, but as I said, it could sort of be flexible 1 or 2 centimeters either way.
Hello, hi, I'm Dr. Ajay here.
Yeah, hi Ajay.
Dr.
Hi
Arvind.
Ajay.
Hi.
Yeah,
Hi.
yeah, hi Ajay.
Hi, sir.
Hi.
Yeah, sorry, I joined in a bit late. I just was coming when you were talking about the laryngeal release. I have a couple of comments, if I may. Can I?
Sure. Please go ahead.
My experience is more with benign tracheal stenosis,
Right.
post-indication tracheal stenosis.
Right.
The laryngeal release, what I noticed is they cause a lot of deglutition problems. What is your experience regarding the deglutition problems with the laryngeal release?
Yeah, absolutely. I did briefly mention about that. So, the important thing is to sort of release only if it is necessary. The Montgomery release, if you actually do it very superficially, some of these superficial fibers of the muscles you cut, they don't go into that much of a dysphagia. But you're absolutely right. If you tend to do your release much deeper and land up doing a ferriotomy, invariably these patients do get some swallowing problems.
Especially following this corrosive injury and organophosphorus poisoning, the fibrosis is too much in that area, so it's pretty difficult. So what we have resorted to is a retrotracheal dissection. Do you do that a lot, or between?
Yeah, I think corrosive injuries are a different ballgame, because you do get, it's not just the trachea, it involves the cricopharynx, it may involve the esophagus, it may involve. So it is a multi sort of level involvement, and we tend to sort of do circumferential mobilizations only because we exclusively deal with tumors, unlike you all who tend to do more of benign. So what we tend to do, we do only circumferential resections confined to the area of the defect or the tumor and a centimeter above and below. And beyond that, we hesitate to do circumferential dissections. So that's why we are able to sort of maintain the vascularity. And having said that, these inflammatory lesions and sometimes even like vaginous granulomatosis, these are very tricky. Some of the tissues are really bad, and really you must think twice or thrice before doing the anastomosis. I think that's I must say that to operate on a malignancy is relatively easier. To operate on corrosive strictures is extremely sort of difficult, and it may not be that much gratifying. And even the stenosis that happens following endotracheal intubations, because they tend to occur at a much higher level. They tend to occur close to the cricoid level. And sometimes your anastomosis will actually be some of the sutures you'll be taking the cricoid. Sometimes you do a partial cricoid resection.
Cricoidotomy.
Yeah. So these things, and I did briefly mention that. I'm glad that you, as an expert, brought about those points. But that whenever we do a partial cricoid resections or a laryngotracheal resection, these tend to be very complex. And a lot more complications to set in because of this. And more often than not, we would tend to use the Montgomery tubes as...
that's what I was about to tell. We use that as a prophylaxis you put it and then remove it after 2 weeks to 3 weeks usually.
Correct. You could sort of use it much longer as well, up to 6 months. Also, you could use it depending upon the case. But I think I'm glad, Ajay, that you joined and could give us these points. Nice to see you. Yeah. There are some other questions. Iatrogenic esophageal injury after primary closure. Esophageal injuries may not sort of be that much of a problem, because as I said, they tend to involve the serosa itself. So the most important layer of the esophagus is the submucosal layer, and if you have not reached the submucosal layer, you are good. But even then, if you have done an inadvertent mucosal injury or a submucosal injury also, I think if your tissues are good, you should be able to do a primary suturing and across that area. And esophagus may not be a bigger issue, especially in cases of thyroid carcinomas. Oh, great. And the time is pre-operatively it is possible to lengthen the trachea. Pre-operatively lengthening, I don't quite understand what the question means. What you can do definitely pre-operatively is you can map the trachea. So that is something that we need to do, as I said, by doing a virtual bronchoscopy and a CT scan. We will be able to map it. And the lengthening or something like that is, I think, if you could sort of come and explain to me, I think, what you exactly wanted to tell, then I could possibly answer you better. But Preoperative lengthening is something that I'm not I'm not sure what you are meaning by that. But definitely, I think intraoperatively, as I said, we can sort of do the release maneuvers.
So on that note, Arvind, thanks for a nice lecture and wonderful discussion. Thanks, Ajay, for joining in.
Thank you, sir.
I don't know where Arvind got his haircut, but just like you, even I have trouble with my hair.
Home, sir. We manage with the clippers.
Really? Thank you so much again. And Arvind will come back with the advances in thyroid malignancies sometime, as and when your time permits.
Sure, sir. My pleasure to be in this. And thank you, sir. It's been 1 hour and it just happened so quickly. I didn't realize. Thank you once again.
Thanks everyone for being here. Thank you. I shall close the session.